Right, that's even more people in. So thanks everybody for coming. My name is Martin Murchie. I'm co-director of the Health Determinants Research Collaboration in Aberdeen. Welcome to this first of a series of seminars from the HDRC in 2025. We're calling this Learning Together for Better Lives, and this is our launch event. So thanks everybody for giving up your precious time this afternoon. We've got high caliber speakers today. We've got first Professor Shantini Paranjothy, who is the Deputy Director of Public Health at NHS Grampian, and Shantini is my co-director on the Health Determinants Research Collaboration. Then we've got Angela Scott, who most people will know, Chief Executive of Aberdeen City Council, and we've got Helen Cannings, who's the manager of the Health Determinants Research Collaboration. So all three of our speakers are going to be looking today and talking about the social determinants of health, but looking at it from three different perspectives. Shantini is going to be discussing the determinants of health from a public health perspective. That's her professional background. Angela's going to talk from an organisational point of view and from Aberdeen City Council's organisational point of view. And Helen is going to give us her individual professional perspective. Helen's also going to provide us with some information on how to get involved in lots of the activity that HDRC is involved in, and give some details on the other seminars as part of this programme of events and other things that we're doing this year. There's a live Q&A feature in the session, so I'd encourage everybody to take advantage of that, and please ask your questions there. There's also the live chat feature, so if you don't want to ask a question but you've got a comment to say, just we can put it in the chat as well. So for just now, microphones and cameras are switched off, but we've got about an hour probably scheduled for this, and the speakers aren't going to take that long. So when we get through the questions, we're going to switch the microphones and cameras back on for a bit of a general discussion if people prefer to put their hand up and ask some questions of our speakers. So just a couple more things. So the set, just for keep everybody right, the session's recorded. And I think that's it. That's my one thing. So I will get off and hand over now to Shantini.
That's great. Thank you, Martin. So it's a pleasure to be here today. And over the next 15 minutes or so, I'm going to introduce the social determinants of health, their role in health inequalities, and finally talk about some approaches and things that we have in our public health toolkit that can help us to drive improvements in population health outcomes and reduce inequalities. Next slide. So I'm going to start with the population health context in Scotland and then in Grampian. So this slide shows the trend in premature mortality, and that's deaths before the age of 75 across Scotland. The orange line is Scotland, blue for those living in the poorest areas, and yellow for those living in the wealthiest areas. Until about 2014, so that's about a decade ago, we were steadily making progress in reducing premature mortality rates. But this stalled for a period of about 5 years during 2014 to 2019, so before the pandemic. And now premature mortality is increasing and increasing faster in some of the poorest areas in Scotland. The picture in Grampian is similar. So people are spending more time in ill health. Overall, people start to experience ill health by the time they are 60, and often this is with more than one health problem. But in our most deprived areas, this starts to happen by age 40. So life expectancy overall in Grampian is 78 years for men and 82 years for women, but this varies according to where you live. And I'll show you how this varies in the city in a minute. Overall, cancer and heart disease are the leading causes of death, and rates of death from these causes are higher in our most deprived areas. Smoking and obesity are the leading factors that contribute to a significant proportion of these deaths, and we have higher rates of these risk factors in our most deprived areas. The biggest difference that we see in death rates, though, is for drug-related deaths, where the rate is 7 times higher in the most deprived areas. Next slide. So this slide shows life expectancy for males and females in Aberdeen City, and men who live in the most deprived areas, so for example, Torry, Woodside and Northfield, are dying 10 years earlier than their peers who live in wealthier areas such as the West End. For women, this difference is about 8 years. Next slide. So so these differences are unfair and avoidable, and this is what we refer to as health inequalities. Our ambition is for people of Aberdeen City and Grampian to live more years in good health. And to do this, we need to improve health for everyone whilst improving health for the poorest fastest. So to make a difference, though, we need to understand people's experiences and work with people in communities. This slide shows some quotes from a number of case studies compiled by the Station House Media Unit for Challenge Poverty Week last year, and really gets across some of the challenges that people are facing. The impact of not having a secure job or enough money will often also mean not having healthy food or a warm home or ability to travel across services. Next slide. We see this change in people's living conditions in our data as well. So the blue lines on these graphs are for Aberdeen City and the purple lines are for Scotland. And you can see the percentage of households affected by food insecurity or fuel poverty has been increasing over the last 10 years or so since 2016. Next slide. So the social determinants of health were defined by the World Health Organization in 2008 as the circumstances in which people are born, grow up, live, work, and age, and the systems put in place to deal with illness. These circumstances are in turn shaped by a wider set of forces such as economics, social policies, and politics, or as more simply put by Sir Professor Michael Marmot, it's the causes of the causes. So over 30 years ago, Dahlgren and Whitehead created this rainbow model of the social determinants of health. The model emphasizes that individual behavior only plays a small part in our health, and that health is in fact determined by the factors that characterize our living and working conditions. So things like food production, education, employment, housing, and access to health and care services. Key to understanding this model, though, is an appreciation that the four layers of determinants or the rainbow are interlinked. So there are vertical links between the social, economic, and cultural determinants of health and those of lifestyle. And therefore, the point that actually the higher rates of risky health behaviors that we observe are often structurally determined and not really lifestyle choices as such. Next slide. So when we look at what shapes our health, the evidence base tells us that social and economic factors, or what we also call the wider determinants of health or the social determinants of health, and the environment we live in accounts for about 50% of the health inequalities that we see. The remaining 50% is attributable to health behaviors and access to good health services. Next slide. So this slide illustrates how the underlying health gradient that's due to inequalities in the social determinants of health can make it difficult for individuals to change their health behaviors. As a result, some health improvement programs that are aimed at individual behavior change can have short-term effects, requiring constant reinforcement. So now there's a greater emphasis on upstream or earlier causes, including the effect of the built environment on people's behaviors related to diet, travel, work, and so on. Next slide. So where do we focus our efforts if we want to address the social determinants of health and reduce inequalities? So Sir Professor Michael Marmot and the Institute of Equity have laid out the evidence base around this and outlined 8 policy areas that require action. This will include giving every child the best start in life, creating fair employment and good work for all, creating and developing healthy and sustainable places and communities, all things that we're quite familiar with and things that we have in our strategies and work plans in the work that we do. Next slide. And one of the key concepts relating to reducing health inequalities is proportionate universalism. And this is about improving health for everyone, whilst also improving health for the poorest fastest, and recognizing that people have different needs and therefore treating everyone the same will not lead to equitable outcomes because some people will have different needs and need a little bit more to get the same outcomes as their peers. One of the challenges, though, is to look at how we implement this in practice. I've been working on some guidance on how to do this with colleagues in Public Health and Public Health Scotland, which we hope will be published soon. But there are really not many examples out there in the published literature where this has been done consistently. But certainly there is an evolving evidence base and there's lots of scope to explore how we do this and how to implement this. Next slide. So in Grampian, we've adopted the King's Fund 4 Pillars model for population health to help with framing how we look at the social and economic factors, as well as behaviours and access to health and care. So all organisations have a contribution to make to each of these pillars, and equally the pillars overlap. So if you live in a deprived area, the chances are your local shops will sell expensive, unhealthy food. So what are the levers that we have to make healthy food more accessible in places and also through our respective organisations? Next slide. So if we are to make a difference, we need to take a whole system approach. And this is a map of some of the actions relating to each of the 4 pillars in the population health model in a whole system approach to healthy weight. So the actions range from things like planning policies, food advertising, workplace policies, and opportunities to address the obesogenic environment through local development plans. Next slide. So what I have been talking about so far is how we take a population health approach to address the social determinants of health and reduce health inequalities. And what I want to turn to now in the rest of the presentation is population health management. And that relates to how we improve population health through data-driven planning and delivery of services to achieve maximum impact. Next slide. So through the Health Determinants Research Collaborative in Aberdeen, we've brought together the data infrastructure and expertise that's needed to support an evidence-based approach to population health management. We have a number of work streams that are designed to support our use of data and evidence, translation of evidence into practice, and stimulate and support interdisciplinary research. Next slide. So I'll illustrate how, no, go back on, sorry. So I'll illustrate how all of this works, just using the example of some work we've been doing to address the rising cost of living. So HDRC researchers reviewed the evidence-based and produced a policy and practice briefings, actually, 2 policy and practice briefings, one on mitigating the impacts of the rising cost of living and another on interventions to address fuel poverty. So these provided an overview of what works and the areas where we should target action. And sometimes the evidence base is not clear. So on balance, then, some areas that we can look at and areas where we would really need to try and innovate and wrap around some evaluation. So we engaged with partners to understand what is working, the challenges and barriers, and what became clear was that there was more we needed to do to strengthen how we evaluate some of our activities to understand its impact. And we also worked with Energy Systems Catapult on a test of change, where we delivered warm home prescriptions to households in deprived areas, where there was someone in the household with a respiratory condition that could get worse due to exposure to cold temperatures in the home. Based on the learning from this, last winter we worked again with Energy Systems Catapult to test a modified intervention, and this is currently being evaluated by ESC, Energy Systems Catapult. So through this work and the work that Martin Murchie is taking forward on the low income families tracker, we're starting to develop some of the data infrastructure and capability that enables us to identify cohorts of people that can be targeted with interventions. And we're starting to build a program of work that's focused on housing and health. Next slide. So I hope you're still with me, and I hope you're thinking, so how is all of this going to help me with that, what I'm working on now? So one of the things we're here to do as a HDRC is to facilitate learning and capacity building to support evidence-based practice. So over the next few slides, I want to give you a flavour of some of the things we have in our public health toolkit that can support with population health management. Next slide. So firstly, how do we systematically search for evidence about what works? And typically this will be published, this will be papers or published literature in peer-reviewed journals. We have a number of tools that we can use to critically appraise what we find, assess the quality of studies and their validity, and then be able to make a judgment on whether or not those findings are relevant to our context in practice, and therefore then how we can or can't use these findings in our practice. Next slide. Secondly, health needs assessments. So in public health, we define need as the capacity to benefit. And the health needs assessment is about systematically identifying unmet need and making changes to meet these unmet needs. And really, we want to try and get the overlap between need, demand, and supply to be as big as possible. So next slide. So typically when we do a health needs assessment, there are three approaches that we can use, and often these are combined. So we've got the comparative approach where we look at how we're doing compared to others. The corporate approach, which really is about stakeholder engagement and looking at what our stakeholders think. And finally, the epidemiological approach, where we use quantitative data and health economics data to understand the current picture, trends, and so on. Next slide. Finally, I want to talk a little bit about evaluation. And there are many different types of evaluations depending on the audience and the purpose. Typically in tests of change, we probably want to shape the intervention or understand how it is working. And for these, you would need formative or process evaluations. If we want to know if something's working and how effective it is, then we would be looking at an outcome or an impact evaluation. What's important here is that we choose the right study design or method for the type of questions we want to answer. And often we will need a combination of study designs to address the different aspects of the evaluation, especially if it is of a wider program or a service with a number of different elements. The next slide. So one thing about evaluating impact, we need to be mindful of timelines and how long it can take to measure the impact on health outcomes for some interventions. So if our ambition is around reducing mortality, and if our intervention is specifically in population groups with specific diseases, then this is probably achievable in the relatively short term. But if we're intervening through behavioral change, so for example, smoking cessation programs, reducing alcohol-related harm, and those kinds of interventions, then we will probably only have an impact on mortality rates in the medium term. And then if we're addressing the social determinants of health, then that will have a much longer gestation period, and we're likely to see the impacts on outcomes such as mortality rates in the much longer term. And therefore, but that doesn't mean that you won't see impacts on other outcomes that are more proximal in relatively shorter timeframes. Next slide. So what I've done really is given you a bit of a whistle stop kind of tour around population health management and some of the things, you know, we can try and do. But ultimately, this is all about learning and applying what we learn to practice. So we've got the infrastructure and the tools, and we can use these systematically to address the social determinants of health and reduce inequalities. And by doing that, try and be more focused in where and how we target our interventions to address the needs of our population. I think that's all I was going to say. So thank you.
Thanks, Shantini, and lovely to see the round of applause for you. That was really, really helpful, and I'm hoping to take the baton from you, Shantini, and put that into the context of what that means for Aberdeen City Council. So can I maybe just move to the next slide, please? I wanted to just, I guess, do a wee bit of a history and just remind us about local government and our past, and talk about how the past has shaped what we currently do, and try and share a wee bit around our future, but all of it being hinged around the determinants of population health. So again, for those that do know their history, local government has played a long role in tackling housing and the problem of housing, and what you have here is an image of slums, and again the role that local government has played in the demolition of all this type of housing and the upgrading of housing and shelter being a kind of key aspect of how we live our lives. But history tells us more around what and explains more about why we're doing the things that we're currently doing as a local authority. And I've just got some examples that I wanted to share with you. If I could move to the next slide, please. So it's fascinating to think about why we hold functions, some of the functions that we do. So for example, why do we hold the registrar function within local government? And part of that definitely stems from the history. And again, history demonstrates that you know, our knowledge of death rates and causes of death was incredibly patchy, and it was all Shantini's predecessors that in trying to understand the poor health that was taking place, the importance to start to track and understand the pattern and the prevalence of disease and rates of death, which led itself to the establishment of the registrar. And in 1855, the Civil Registrar of Births and Deaths was introduced. And lo and behold, we continue as a local authority to play a role in the maintenance of that register. Equally, again, when you go back into history, what history shows us is it wasn't uncommon, particularly in cities, that you could have 12 to 16 people living in one room. And again, you know, the public health intervention to that was house building. And as we know, local government has played a long role in housing, and we continue to do today. 22,000 properties that we are the landlord for in the city, and of course we shape not only our own housing offer, but we shape private sector and social rented offer as well, and we play a role in part in regulating private sector rental too. So we continue to play an incredibly strong role in housing. And of course, history also says that in the early 1880s, infant mortality in Scotland was 120 per 1,000 live births and healths of children, which itself then led to the introduction of the Education Act 1908, which created compulsory medical inspection of school children. And of course, remember, local government were required to have a medical inspector. So the health system actually started in local government, and it's only been in the post-war era that we recognise the health system as it is today. But local government was required to have a medical inspector. If I can go on to the next slide, please. So again, you just continue to see how the past has shaped what we're currently doing. 1919 saw the introduction of maternity and child welfare schemes were introduced. Local authorities were empowered to provide food and clothes for those children who were classed as poor or needy. Again, we're still doing that today. We continue to offer grants to families that need support. And again, interestingly, local authorities were responsible for vaccination. And interesting that, over time that moved to NHS. And then interestingly, in the modern era, how it's moving back into to local government via our health and social care partnership. And again, vaccination seen as an important public health intervention. And we, of course, played a part in that. Next slide, please. Again, it's just interesting looking at, again, the past and understanding the causes of disease and the role that toxic odours played in the atmosphere, and again, how all of that came from dirt and poor sanitation, some of which you saw in that earlier image of housing, and how poor sanitation itself led to the spread of disease. What was the solution? The solution was to place a duty on local authorities to clean up the streets and provide an efficient means of disposing human waste. And again, for those that know your history, at a point in time, local authorities had responsibility for water, and Scottish Water, as we know it today, is only an incarnation post local government reorganisation in 1996. However, we continue to play a role in dealing with waste, street and human waste, and again, trying to protect the public's health. I've mentioned there the role that historically we played in the water supply. Again, that function has largely moved out of local government since 1996, but we continue to play and have a relationship with Scottish Water. Some of you will be familiar that we entered into a growth agreement, again, trying to ensure and support Scottish Water to make sure that there's clean water supplies in the city, and the impact that the flood risk can have on the purity of that water supply for the city. Again, history demonstrates that poor conditions in the workplace were a real risk, and particularly, I guess, if we recall that children were often working in the workplace too in the past, that there was a recognised need to regulate workplace conditions. And again, where did that role get placed? It got placed on local authorities through the 1897 Act. And then the final one I just wanted to flag up here was about food and drink pollution, and again, the need to regulate that and the introduction of legislation. If I can move on to the next slide. I won't dwell on this one again, but again, just given more examples around how the historical understanding of the role that living and working conditions and the social and community networks and the individual and lifestyle factors that Shantini's introduced us, that her predecessors were recognising all of that way back in 18th and 19th century, and in recognition that interventions were required, they placed those interventions on the predecessors to the form of local government that we sit in today. And of course, local government has changed its shape over time, but there was a recognition that local government sat in communities, and if we wanted to make a difference to the population health, then we needed to influence the living and working conditions, the social and community networks, and try and influence lifestyle choices. And the role and responsibility for that was placed on local government. And I think, the evidence is there. I would often make the argument that we are a public health body. That's the core of what our function is. If I could just move on to the next slide. So we are experiencing different aspects today, probably characterise these more around some of it being individual lifestyle choices, but some of it, as Shantini said, part of the environment within which we're living. So what you see is the image on the left there demonstrating levels of obesity. There are aspects of choice, but again, if we look at the environment within which we are living, if we look at, if you were walking your children to school, how many takeaways would you be walking past? What would be all the advertisements that you would see? But equally, how difficult is it to afford good food? good and nutritious food at an affordable rate as well, and how much is that contributing to levels of obesity. Pre and post the pandemic, again, we are seeing levels of mental health and particularly levels of anxiety in young children, which is presenting itself. And I think Shantini's already referenced around drug and alcohol and those behaviours. Some of those aspects, of course, were in the past. So for me, I guess our past and our present are characterised by trying to tackle living and working conditions, trying to tackle social and community factors, and trying to respond to and influence individual lifestyle factors. And over our history as local government, you see governments and the spheres of government around us placing more emphasis on different aspects of those interventions. But it's fair to say that I think our history demonstrates that we've been active in all aspects of that throughout the life of local government. So looking to the future, if I could just move to the next, sorry, so I forgot we dropped this one in. Again, I just picked this back up from Shantini's because I just wanted to reinforce how local government is playing into all of these aspects. So whether it's the physical environment, through things like our low emission zone and the work we're doing on active travel, or indeed the work that colleagues are doing within planning around our local development plan, or indeed the work that we are doing through our health and social care partnership, and including health services and influencing the design of those, as well as trying to influence health behaviours, as well as trying to contribute to social and economic factors. Again, lots of colleagues in the organisation working really hard to influence the economy of Aberdeen and its transition from fossil fuel to low carbon, as well as diversifying as well. So I think it's certainly easy for me to see where ACC footprint sits in every single one of those categories around the determinants of population health. If I could just move to the next slide. So I guess in terms of our future, it connects into where we're at, and I'd probably pick up the baton from Shantini around the population health management. I think the partnership that we've entered into through HDRC in particular is around helping us to understand data and joining up our data. And I know that can be an Achilles heel for many colleagues in the organisation, but we are significantly investing in order to get smarter around our data. Shantini made the reference around targeting communities. So going beyond just universal provision and really thinking about our targeted communities. The partnership with Professor Marmot in the UCL and Aberdeen City Council being selected for one of those pathfinders is really going to help us take a different approach to targeting. And our two areas in the city are Northfield and Torry. Again, we have a strong history of working with both of those communities. I'm just hoping that through the work with Marmot that we strengthen that approach to really focusing on those communities that are experiencing the worst outcomes. And Shantini made reference also to thinking about how we deliver our services. And again, colleagues will be familiar with much of the work that we are doing, particularly around family support model, how we can integrate our services far more, not only within ACC, but also within our partnerships as well. And again, if I reference us back to the Christie Commission, which made many of these points about data, the need to be targeted and the need to integrate services as well. So I think our future, if I'm being honest, is both our past and our present. Local government has always been about the determinants of population health. It's always been about public health, and it's always been about public health management. And I genuinely don't see that changing. I think there's just a bit around how we can use technology and data in particular to help us to strengthen that, and how we can use public sector reform in order to integrate our service delivery, but also make sure that those services are what the public need from us. So our future for me is very much our past and our present, and our organisational structure I thought it was really important to signal that we are an organisation about public health, and the focus of our structure and the alignment to the determinants of population health has been very deliberate on my part, just to really underscore that contribution that we do make. I hope I've segued nicely, Shantini, from yours, and Helen, I hope I've given you a nice segue into to your input. So over to you, Helen.
Okay, cool.
Okay, well, Angela and Shantini are a pretty hard act to follow, so I'm going to be keeping it brief this morning, and I think echoing some of the stuff that's already been said. So in terms of what the wider determinants of health mean to me, it's pretty straightforward. For me, they provide a clear and unifying focus on the council's role in shaping health. As Shantini and Angela have covered, the building blocks which shape people's health sit across partners, and we've got mature partnership working arrangements in place already, and they've been there for some time. So in the context of that wider system, the HDRC has a focus on the wider determinants of health, and we also have a particular focus on the council. So I've worked at the council for a long time now. It feels like a long time, 14 years, and I actually did start out in the archives, so worked a lot with all the records around the council's historic role in health. And all of my time up until I came into the HDRC has been focused around information and data in one way or another. My first job as an FOI officer gave me a bit of a crash course in the breadth and diversity of local government functions, services and priorities, and the extent to which they shape the place and the lives of people who live here, visit here, work here. What it also gave me is a really keen sense of just how important these things are to the public as well through the requests that were made. So I think my experiences, whilst terms like the wider determinants of health might be kind of new-ish to us at the council, but the fact that people's circumstances shape their health, it's not really new to anyone who works here. In my previous role as the council's data protection officer, I worked on loads of projects to improve data quality, integration and sharing between partners. And these are probably the things that meant the most to me, because I saw how things like data sharing are just an essential foundation for collaborative working. And collaborative working in a way that you can directly see leads to a difference for people. There's lots of examples, and I think Angela touched on a few of them already, but from the very specific things like enabling pharmacy deliveries to people in their home in the early COVID lockdown, to much bigger arrangements where we're able to share the data that we need to provide integrated health and care services, or to project-based stuff like the Fit Like family wellbeing hubs, where partners are coming together around families. So I suppose I know what can be done when we work together in a way that's focused on people. And for me, a lot of the attraction around the HDRC was being part of finding out what difference we can make if we go broader than data. So yes, data's fundamentally important, but it's a foundation. So data and evidence and research, and being able to bring in expertise from academia, public health and other areas to support us was one of the things that I really felt was strong about the HDRC. And this is one of the things that we want to do with our seminar series. Emma, whether you can take me on to the next slide. So our seminars are going to run regularly over the next year. They're going to bring some of the things that Shantini touched on into a bit more of an in-depth treatment. We will have guest speakers coming in from our collaboration partners, but also from further afield. And we want to kind of explore more some of those methods and approaches from academia, from public health and from other places. And we want to explore how we can apply them in a council environment. So each guest speaker will be joined by a member of the HDRC team who will be on hand to, I guess, facilitate conversations and make links into applying these approaches into a council context. As we've got today, the seminars are also going to include time for discussion and time for questions. So for council officers, we are also launching a research collaboration hub. So this is going to be a network that's open to anyone interested in evidence-based decision making. And through this network, the HDRC is going to offer a range of activities, including Meet the Researcher sessions, research data analysis workshops, to really further that skills and embed those approaches together. So I suppose that brings me back to the theme of the seminars. It is about us learning together. So hopefully we'll see you all at our future seminars, and I really look forward to the discussion and the actions that come out of them. Thanks very much.
Thanks, Helen. And thank you, Shantini and Angela. I hope people found that interesting. I think as a introduction for the seminar series that we're going to put on for 2025, that was a pretty good introduction. It kind of set the professional background around public health and the current thinking. And I think crucially for us as an organisation in Aberdeen City Council, just reinforcing from Angela that message around this organisation essentially being public health. As I've challenged my colleagues and peers many times over the last year and a bit, when since we've had the HDRC, to tell me something that they do which doesn't in some way impact on health, and I'm still waiting for anyone to take me up on that challenge. So if we unmuted people now, yeah?
Yeah.
Cool. So we've only got one question in the Q&A, which we'll take that one, because I actually think it's a pretty challenging question, and it's kind of on the money. So Bob is asking us here, do we have any relatable stories which demonstrate positive outcomes that have been achieved? And I think I would take that in a, I mean, Bob, you can tell me not to, but take that in a broad context of public health in Aberdeen as well as HDRC. So I'm trying desperately not to answer that question myself. But I will take a back seat and see if Shantini, Angela, or Helen want to jump in there.
Do you want me to go first? Oh, Angela, you go.
Angela.
Thanks. Well, it's a really interesting question, Bob, because I think we've got no shortage of stories. So you know, if I looked at best start in life for children, if I look at levels of attainment that in particular we've got, if I stuck with children, Bob, and I walked through child's life, and going from that early years, and again the developmental milestones that we have, the number of children in the city that we've got that are passing those critical developmental milestones in those early years. If I then look at the attainment, and again the milestones from primary school into secondary school, if I look at the amount of children that Bob, that are coming from secondary school into positive destinations, into positive working and so on, that I can walk through the whole life of a child, and I think we've got lots of evidence of positivity, and I think we've got lots of relatable stories in there. I think I'm going to take your challenge, which is around perhaps the more challenge where we're not making the difference, and that's where I think we are challenged to make sure we're getting the lived experience voice out of those that where we're not managing to make the progress. I think the challenge, Bob, is that we're touching so many parts of the population health. I think we find it difficult as a system. We describe an awful lot of what we're doing through formal annual reports that were required, and it's complex and it's large. And I think, like all organisations, the struggle is how you get all of that in a digestible form. But really open to again to be receptive to how we can enhance all of that, because I'm not sure that we find it necessarily easy to penetrate in the information world that we're in, all the difference that colleagues in ACC and the Health and Social Care Partnership make every day. And I'm not convinced that necessarily everybody understands the touch points that council has with their lives. But I'd be interested to hear your views, Bob, on how we're doing.
Yeah,
Okay,
Bob,
I
you
guess
come in.
I'll turn the question around if I may. But I think about the post office scandal, and until it became a drama documentary, nobody really understood what was happening. And I'd known about 90% of that for 4 years, but it didn't have the engagement. But I think one of the challenges, and I think you touched on it, Angela, was how do we effectively communicate, not just to the academics, not just to the professionals, but to I call it the Tory man, the person who drinks in a pub on Tory on a Friday night. Speak that language. And as you know, communication is the different optimums for communication for different demographics. And how we can identify that and how we can tailor our communication strategy to engage the whole Aberdeen community. And I think, not being rude, but I think there is a challenge at the moment. It's everybody's, let's call it Abermoners, and the media don't help, concentrating on the negatives. Let's start looking at the positives and in a way, marketing what the council do and showing, yes, there is a lot of good stuff that's being done, a lot of positive achievements. And can you help us, please? Yep, I'll stop there. I've probably said enough.
Thanks, Bob. I'm just pausing to see if anybody wants to come back in on that. Okay. So thanks, Bob, and thanks, Angela, for that. Baldeep has put a question in, which is another good question. Thanks, Baldeep. So how do we think we can make healthcare systems be more inclusive and equitable as we keep in mind the competition for resources? Nicely set up. Who wants to come in on that? Well, I'm gonna nominate Shantini to come in on that one.
Sorry, Martin, I was looking a bit, I couldn't see the questions, and so I missed what you were saying.
Do you want me to read it again?
Yeah, go on then.
Yeah.
Thank you.
How do we think we can make healthcare systems be more inclusive and equitable as we keep in mind the competition for resources?
Yeah, okay, so that's a good question. So I think access to health and care systems continues to be, something that we are working on and need to work on. So we have we have got a Grampian health equity strategy, and one of the things in there is looking at access as well. So I think in lots of ways we do need to go back and listen to what people tell us about the barriers to accessing health and care, and actually maybe within as healthcare providers we need to get a bit better about putting ourselves in people's shoes, so seeing it from people's perspective, so we're making the connections internally to make our services more person-centered. And we've got several streams of work trying to look at this, and certainly we've got examples as well where we're starting to do that. So for example, with our screening programs, where we know uptake is not great with some communities in the city, we've worked with them and really tried to understand why things weren't working. So for example, the messaging that we're using in some of our invite letters, or some of the ways in which we talk about screening, the language we're using doesn't chime with people. And so we worked with those communities to amend our messaging and we're just starting to put that into practice now to test how that might work. So we've really started to tailor our messaging according to, you know, to be able to target communities in a better way. And it's so what we learn from that, we are hoping to apply to our vaccination programs as well, and various other strands of work. The key thing for us, though, I think we've gone into a space where we've become very specialist, or very much specialists in silos. So we want to deliver a service and then another service and another service. So we're constantly going to the same groups of people on lots of different things. So actually, we probably just need to take a step back and re-look at, you know, how we wrap around families or wrap around individuals, but actually, you know, it's providing more of a one kind of one-stop shop type thing. You know, so you're addressing lots of different things that are important at that particular time for that person in a more holistic and comprehensive way.
Thanks, Shantini. I think Angela wants to come in on that.
Yeah, Baldeep, a really nice, easy question from you. Absolutely not. I just wanted to pick up a couple of your words. So access, and rightly, Baldeep, your unrelenting attention is around protected characteristics, isn't it? And the access of those with protected characteristics to all services. And so I think there's a fundamental challenge in there around how accessible are all services to all those with protected characteristics. And again, history, if I think about how the city of Aberdeen is designed, it was designed at a point in time when, for example, women were not in the workplace. And women did not come into work, and the city was designed to allow men to come into to the city, and that's the gender story of. So the city itself wasn't designed for women. And we deal with the consequences of that today. And so I make that point in the sense that Baldeep, our services start from a premise around a historical determinant of what influenced the design, who had to get access when and where. And there's some fundamental challenge now around how we really tackle some of those access issues. I also think to the point around access, if I took us back to Shantini's earlier slides, access must not be at the point of which the inequality gap has totally embedded, so that actually that what we're dealing with is people in their 50s with multiple health conditions and saying, oh, let's give you access to. I think your challenge is around how we give access to health, good health and health prevention, and how that starts often from pre-birth, but particularly into early years and into primary and so on. And so how habits of good living and good health are actually embedded in those early years. So things like the daily mile in school, where the kiddies are out running, and trying to make that a part of looking at our active travel, getting families to walk to school rather than use cars. So I think when we talk about access to health, for me, Baldeep, it's not about access to the health system, the health treatment system, but it's access to many of the facilities that the council's got. So as well as I, the fantastic parks that we invest a huge amount of money in. And actually, if I come back to the characteristic of somebody with obesity, is somebody with obesity going to access the sports village? Are they going to access ARI? Or actually, might we have more chance about getting active within their community and within a green space within their immediate neighbourhood of 20 minutes, where actually everything is on the doorstep? So a bit like Bob, I'm kind of flipping your question, Baldeep, because I think it's about really challenging us about, there's an immediate reaction to your question about access and access to the current paradigm of health and social care. and access, tackling some of those historical biases that maybe made access difficult, but also thinking about access from that preventative perspective, and actually saying if what we're trying to do is to instill good health, then actually the access is to a broader set of assets and activities, much of which sits in the community, much of which exists in Sport Aberdeen, in the Sports Village, in community wardens, in our libraries. And again, you'll be familiar with the work we're attempting to do on 21st century libraries, where again we try to get people connecting back into buildings that are in their community and how we can use that to engage with people on good health. So for me, Baldeep, it's about just sort of flipping your question a wee bit. You're right to check us about the access. We've not tackled all of that, but I think access to a broader set of assets, which are both physical assets and people assets, and how we really start to get upstream. Our health inequality issues are pretty systemic in Scotland. Bad health is not new. I don't. If I go back in my generations, I can see the patterns that were established, but from my family generations, and what I've attempted to do to kind of correct that with some of my children. I'm delighted that neither of my children smoke. But that was a policy intervention that's changed that kind of generational behaviour, and these are the kind of things I think, Baldeep, we've got to be thinking about in some of these bold decisions to tackle some of that health inequality, because the health treatment system won't do it. So I'm sorry I flipped your question, Baldeep, but I hope you don't mind that.
Thanks, Angela. I'm going to try and squeeze a few things in before three. We can go over the time a little bit, but I suspect people will start to have to go to other meetings at 3. So just in turning to the chat rather than the Q&A. So Kenneth, you've put a couple of points in there, which I'll quickly sort of deal with. So don't underestimate the health benefit of improving housing. Just to say absolutely, and I've put a heart to that, and I noticed that Kay Dyack has as well, who's a member of the Housing Board. So we're working through the Housing Board with our colleagues in NHS Grampian and others around some important stuff around housing, from the housing strategy through to data matching between NHS and ourselves in terms of the housing and the people who live there and their health. So that's absolutely on the money. Just your second point, Kenneth, about the extent to which HCRC feels responsible for implementation of NICE guidelines around cardiovascular disease and mentioning statins. So I think I refer you to Angela's answer to Baldeep's question around all of the ways that the local authority and in its partnership capacity through HDRC gets involved in the non-clinical aspects that would go to support the prevention of cardiovascular disease. So not specifically the prescription of statins or any other drugs, but it's all those other things that we're involved in. So there were a couple of other questions. Just quickly back to them. So Amy has got a question. Is there knowledge or guidance on how to target public health messaging and guidance through social media to increase reach? Yeah, that's maybe another one for you, Shantini, around public health.
Yeah, so there is a whole body of evidence around how you target messaging, or how you develop effective public health messaging, and so certainly in public health we've done some work with behavioral psychologists at the University of Aberdeen, where we're looking at how we develop appropriate public health messages for pregnant women around a number of issues. So I wonder whether that's the kind of thing, maybe that's maybe that's the kind of thing that might be worth having a bit of a session on. So I'm sure we can look at how we share some of that skills, or do a session on how we can develop or have a think through what are the things that you can use to help support with that kind of work. So we can take that away, Martin, I think, can't we?
Yeah. Thanks, Shantini. I think so. Val has got a question as well, which I don't think it's a million miles away from that area, though probably speaks to work around things like the Fair Futures work as well and design of services. So Val's question is, can we work towards an approach where we can link and integrate, I guess, the offer of health support in the same way that we do that for social and monetary support to low-income families? So she says similarly elderly support and access to health support screening. So I think what I'm taking out of that is some reimagining of collaborative work to engage people and offer and push joined up health support and health advice. So I think that's what I'm taking from that question. Val, correct me if that's not right. Anybody want to jump in there? Angela.
Yeah, thanks for the question, Val. I mean, I guess linking it back to data, there's a lot of work, and Martin, you're at the front of all of this around actually in terms of some of that entitlement, Val, to support, just trying to automate all of that. So, you know, moving away from that position where in the complexity of welfare, and you know, again, that welfare system now sits across 3 spheres of government: UK, Scottish government, and local government. So it's quite a minefield for families to navigate their way across. And so there is definitely, you know, I think we're making good progress on the use of data in order to make sure that families have got the access, in particular, to monetary support. Again, the council's own financial inclusion and the benefit calculator they've been doing are really at the front of that. But I think at the heart of your question is that whole bit around just the whole system support that's required to a family. Whereas, you know, I guess if you look at historically, we've made people navigate different parts. Whereas I think Martin's point, the family support model is about trying to wrap us all around the family rather than make a family navigate their way through the complexity of us. We're starting that journey now on family support model. I think we're going to have a huge amount of learning, because we're going to have to be what a family wants at different times, not the convenience of what suits us. I feel incredibly well supported actually by a number of partners locally and nationally about what would that mean by way of having to change some of the rules that are in the system around, you know, generally we have eligibility criteria and so on that navigates people across services. But as we come together as a set of multi-agency partners around a family and being what that family needs at different times. So I think at the crux of your question is just that whole support, not doing it through the prism of whether it's health or it's education, but all of us tying that all up. That's the journey we're now away to go on to, and we're going to have a huge amount of learning to do from it. We're going to have to rethink how we approach that, but it's definitely at the heart of what you're doing, but aided and supported by some of that data stuff that can absolutely take care, can automate so that people automatically get their entitlement. And Bob, to your point, that actually you don't have to be online to get the entitlement. We're going to make sure that you get the entitlement straight into bank accounts. And I think that's where the 3 spheres of government are trying to use technology. But family support model, we're on that journey. If you're interested in that more, there's a number of reports that have gone through committee. More than happy post this meeting to make sure that folk have got it. And again, welcome people's contribution to the development of that approach, Martin.
But thanks, Angela. I'm just looking forward to the program lead for Fair Futures is starting here next week, so we're really going to get going with that. We've got a hand up, David Fryer. Welcome, David. What's your question?
Okay, thanks. I welcome the ambition, the overview that's been given by all the presenters. What I hope I'm still going to hear is something about the actions, the who, the where, and the what. I'd like to just maybe answer my own question by sharing with you a collaborative partnership between the Old Torry Community Centre and Robert Gordon's University, which once a week brings a physio tutor and has also included students. It started off small. It was a post-COVID intervention we felt we had to do for health and well-being. And now 50 people crowd the door to get in because they so enjoy that intervention, which is physical, social, and community well-being. So it's something we've evolved, and it's perhaps an example that we as one community can share. But I'd just like to add that health inequality and poverty is not new to Tory. They go hand in hand, go way back. So they're quite deep rooted, and the interventions need to be very clearly identified, focused, supported. And the key thing I'd like to put back to you all is continuity. You can't start something for 3 weeks, 6 weeks, a couple of months. They require time and commitment. So that can be a resource commitment in premises and the people who lead projects. So
Thanks,
a couple
David.
of questions. Also offered something that maybe we can share as well. And I'm certain there are other communities that are doing other things. And it would be great to hear what they're doing.
Thanks, David. So if I understand the question is the what and where and how of specifics. I'll just preliminarily say a few things, and maybe somebody else can come in. I think what's come across hopefully through the presentations is the breadth of activity that HDRC touches across the whole of the council and its partners. So there's going to be lots, and there have been already lots of what and where and how. But back to, I think, Bob's question about those relatable stories. Sometimes it's difficult to get your fingers on those because they're already part of existing delivery and development of services that are happening throughout the city. To your point around different parts of the city and health needs, particularly in Tory, absolutely. So one of the messages that we continually make, and this is reinforced by the work we're going to be doing with Professor Marmot and his colleagues, is that if you look at a league table of deprivation and ill health for Aberdeen in the context of Scotland, we place somewhere mid-table, but that isn't really the story. The story is one of inequity and inequality, and our ability to support those most in need is the thing that we're trying to get ourselves closer to and integrate that within decision-making processes of the council, but our other partners as well. We've a range of activity that we are already engaged with, specifically in Tory, but in other areas of the city as well, David. So it's absolutely our intention to hook up with things that are already in place, just to make sure that we can supplement, help, and support those things. I don't know if I just check the hands. Anybody's got their hand up to come in on that one? No, don't. Nobody else coming in. David?
Martin,
Yeah.
just to get follow up, as it involves a university, not surprising that they wanted a bit of validation, and they did that. They talked to us about how best to do that, and they got some real nuggets of comments and quality feedback by the way they engaged our suggestion. And one of our local GPs is very much advocates what we've been doing to address a whole range of health inequalities, whether it's physical or social or health and well-being in its broadest context. So Dr. Crofton knows of our project. You could put it under a kind of social prescribing approach, but he is on the record of saying, here's what can be done.
Great. Thanks, David. Yeah, please do. So just ticking a few boxes there. Robert Gordon University is one of our partners on the HDRC. We're actively involved in social prescribing and, as I said, working in Tory with various partner organisations and community groups. So absolutely pick that one up, David. I don't think I see any more questions. I'll just look around the room in case anybody's going to tell me that there are. No more hands up, and I don't think there's anything in the chat that we need to answer. So I'll draw this to an end. Thanks very much, everybody, for taking the time to come along. As Helen set out, this is event 1 or seminar 1 in our series for 2025. We have other things going on as well. Hopefully some of you will have seen our lunch and learn sessions that are running, and we're around other things too. So there's plenty of opportunities to engage with HDRC, and I hope that you will take those opportunities, or we will come and seek you out and find you. Thanks, Angela, Shantini, Helen, for your presentations. A few folk in the chat have asked for slides. We'll definitely share the slides with people. We've got both internal and external websites, so we will post them up there. Thank you, everyone. Thank you, Emma, for organising. See you later.